So again, we're wrapping up here. Linda, I think you're up next. If you wouldn't like to come to the podium. We are going to have a panel discussion. I'm trying to think of when to place that currently. Why don't we have the physicians that are still here and whatever other patient advocates as well as patients maybe come to the front. We were going to have a panel discussion. Again, I know we're just a little tight on time here, but I'm going to open it up maybe for the next 5 or 10 minutes, somewhat to carry on with discussion that's been initiated here, but I'm going to offer the floor first to the patients when it comes to asking questions specifically to the physicians that are here, what you've learned or questions that have been generated throughout the day that we could potentially guide you in trying to answer.
And I wouldn't mind starting off with a
question. Go
question.
ahead, Michael.
One of the biggest symptoms that I've had with this disease is the severe fatigue. And I know that fatigue comes from both dialysis and aHUS that's been published. My question is, where is it coming from, and can anything be done without the treatment of eculizumab? Where does fatigue come from? Is the disease actually active even though I don't have a major episode going on?
I'm going to come up here. So
Yeah, I've got a microphone here if you want to use it too, Nathan.
So at least from a hematologic perspective, since that's what I'm best able to talk about, I think that it's incredibly complex to say that it's from one place. I think the renal disease is going to provide some of that. But we know that patients who have any sort of hematologic disorder with a marrow that's active and trying to maintain some level of balance is metabolically active and therefore is using up metabolic resources. And there's not as much of a reserve to draw from for that. I use the example in many blood disorders, one common iron deficiency anemia, for instance. There are patients out there who have no evidence of anemia, but have clear iron deficiency and have significant fatigue. And we talk about the fact that iron is used in every cell in the body, not just in the marrow, where you would think if you have enough iron deficiency in the body to cause fatigue, it should also have an effect on the marrow as well. So I would say from a blood perspective, I think there's probably an overactive marrow that is trying to maintain some level of balance. And then we're also talking about that there's complement activation that occurs even at a low level that's going to lead to higher levels of inflammation and contribute to that fatigue.
I just want to add that dialysis, every episode of dialysis is a complement activating procedure. So I think during dialysis, you're activating your complement. I don't think you're having manifestations of atypical aHUS ongoing on dialysis. I'm not recommending to treat you on dialysis, but I believe it's a multifactorial, ESRD by itself, anemia, chronic complement activation while you're on dialysis, depression, anxiety about the illness. So I think it's a multifactorial. And I think after treatment and reversal of the renal failure, patients report improvement in their fatigue, and fatigue is one of the early signs of the recurrence of the disease, like clinical signs. So I think being on dialysis chronically is not helping in the resolution of this fatigue.
And on the other hand, I would say, though, you are doing probably dialysis in as good a form as you can with the nocturnal 5 nights a week. This is probably you would be more fatigued if you were doing sort of in-center 3 times a week dialysis. So you are doing what you need to be doing, I think.
Did you guys have anything else? I had a couple other things.
Go on, Gabe.
I just wanted to comment that aHUS is often referred to as a kidney disease, and I know you guys are very aware of the issues with that, but not all doctors are, and they're still calling it a kidney disease. Even some specialists do. But that doesn't help the understanding of the disease, because there's so many other manifestations of the disease than in the kidneys. So I just hope that the medical community keeps that in mind, that they don't call it a kidney disease. And a blood disease is much more accurate, or even better yet, an autoimmune disease.
Just based on the referral volume that we're getting here locally, I think as physicians, we're becoming more comfortable with the spectrum of presentation. Patients that present primarily with blood inside of their stool, Shiga toxin negative, so we continue the pursuit for a diagnosis, even though with the idea that if you have blood in the stool and they had a hamburger a few days ago, you're thinking this is classical aHUS as compared to aHUS. But there's a volume that we're seeing that at least to the point where I think we're recognizing that it's not simply a renal disease, or what we would have identified in the previous patient that we saw, meaning to say we've seen 10 or 15, and it's building, and I think there's a cumulative effect with that experience.
Mm-hmm.
We are nephrocentric, you're right. This is for us like the organ we focus on, but yes, you're right. Cardiac disease is pretty common. Gut disease is, neurological manifestation. Lung manifestations are common. Clinically, you can distinguish that from TTP that, rarely it involves the lungs. So I think it's, you're right. We focus essentially on the kidney, I think, because we're kidney doctors, but many organs are involved.
One of the things I could say is, and everybody can do this too, so the National Library of Medicine through the NIH allows you to set up searches, and as soon as something new is published, you can have it send you an email alert for certain keywords. So every morning I get an email from NIH that says, these are all the studies that were just indexed in Adams TS13, von Willebrand factor, and a couple of other areas of interest. And one of the things I was very surprised to see was there was a year in which it was a lot of renal and hematology literature, but then all of a sudden there started to be cardiology reports, and they started looking at Adams TS13 levels in acute coronary syndromes and risks, and then all of a sudden there was a lot more in pregnancy and testing levels. So I think that other specialties are starting to see it and start to recognize it, but it gets back to that. The physicians have to be educated and know that it's an issue before they start going to look for it.
How do you do that?
Andrew and I both do this at the Brigham, where we're having discussions with our fellows, and those are the ones who are in training. And I think that the multidisciplinary team approach really does start to help. The house staff, the internal medicine residents that we work with, they are constantly calling because they suspect somebody has one of these disorders now. And we would rather them call and us tell them, no, it's not, than for them to delay that. And you see that, I think, with these multidisciplinary teams, that where they're getting the calls from are now the physicians that are coming out of training that have gone to medical school with this as a disorder, recognized disorder that they had to learn for testing in the boards.
So I don't mean to curtail this at all, but just mindful that there's a number of people that have a schedule that they need to commit to as well. I think we're going to proceed to the next segment in the meeting here. Again, thank you all for participating. It's really been a fantastic